Good morning and welcome to another Albuquerque Fire Rescue podcast. Today we are joined by two members of HEART, and we'll kind of get into what that is. But first, let me start with a little housekeeping. We really appreciate it when you subscribe to our channel. It really helps the channel out. Please like and, of course, leave comments. If you want to be notified when we put up new podcasts, hit that notification bell, and you'll be right in line with that. So I want to introduce Captain Melvin Martinez from HEART and Lieutenant Loriana Sargent from the HEART program as well. Welcome to you both.
Hey, John. What's up?
Hey, thanks for being here.
Sure.
This is something that I know we've talked about for a while that we wanted to do, right? And for me, it was really about, I'm aware of HEART. I know it exists, right? But if I'm being honest, I never really understood exactly what HEART does. So I'd like to start there, right? And then I'll tell you a little bit. So my understanding is that HEART is similar, like most people, most viewers would know community paramedicine, right? We all kind of know what that is, I think by now. So when I think of HEART, that's what I think of, but I know there's some differences and some nuances in the way we do it. Is that right?
That's perfectly right. I guess in a nutshell, you could say HEART is a group of experienced paramedics doing community paramedicine with the focus of like call for prevention through helping our patients, I guess you would say, find permanent solutions to their ailments versus a 15-minute time with them in the EMS system. And so we try to get more in the weeds with our patients and try to help them navigate the healthcare system.
Gotcha. And you're talking specifically about people that call 911.
So we have several programs, but that would be one of them, our repeat patient program for sure.
Okay.
You know, our repeat patient program comes to us through internal referrals by our field crews, and then we go ahead and take a look at them. Lieutenant Sergeant will take a look at what these patients need, and from there it goes out to the other providers, and we get down to finding a solution with these people.
Okay. So it's a referral-based program. How many members are in HEART now?
There's 5 members.
5 members.
Actually, there's 7 members. So we have 3 lieutenants, 2 drivers, captain, and a carpenter.
Oh, carpenter. Okay, I remember reading about that. Carpenter. And so what's your day-to-day like? So you're the captain of the division, and are you seeing patients, or are your responsibilities pure administrative?
So mine seems almost pure administrative. Okay. I do go out if there's something that's a little bit odd because I want to learn. I've been, at the moment, learning all that I can. A lot of mine is handling the day-to-day administrative issues, coordination, schedules, and our lieutenants pretty much handle the bulk of the referrals, and then our drivers handle a lot of the referrals and some of the in-person visits as well.
Okay. So do you also go out and see patients and respond to those referrals? Like, do you have a caseload, so to speak?
Yes.
You do?
Yes.
And then, so how many, because that's not very many people. I mean, 7 members is not very many. How many patients would you say you're responsible for?
It all depends. It will depend a lot on the patients. So some patients may take more time than others.
Gotcha.
So we don't shoot for a number. We're not like, okay, we need 5 or you need 10 on your caseload. If you have a few that are require more resources and more interaction, that's going to take up more of your time. So in order not to spread ourselves too thin, we try not to take on more than we can when it comes to being able to help those people.
Gotcha. So, okay, so because, and I'm trying to decide like how we want to bring this out, but so I know that for some of our field providers, they may not be aware of exactly what HEART does, right? And then I think sometimes we rely on hearsay, right, without actually going to the source, right? So give me a snapshot of a typical day for you.
A typical day? A typical day would involve processing referrals. So every time a field provider puts a referral in, we process that. And to process a referral, we read the referral. It comes into our image trend dashboard, which it has the name of the patient, exactly all the things that the provider put in there, why they're referring them, that kind of thing, phone numbers, addresses. And then what I do with that referral is I'll go and I'll look and see, I merge that patient, because often when, as soon as we open up a patient record, say you're on a 911 call, and you go to put in their information, every time you put in their information, it creates a new patient record.
Okay.
So if Melvin ran on you and I ran on you, there's 2 John McGee records.
Oh.
So Melvin may have run on you 4 times and maybe uses the repeat patient button, and he uses his profile that he created for you, or a record that he created for you.
Sure.
But he doesn't see mine. So we have to go in and merge those records so that we can see all the calls that we ran on you.
To give you a real number of...
A better number, yeah.
better
So
number,
that's
yeah.
why in the Lieutenant Cert course, we always ask to use, and anybody I talk to, please use the repeat patient button. If you put in the patient's last name and hit repeat patient, you'll get a list of that last name, right? And then you find your patient, the first name of that patient, and see if the birth date matches up. And then just hit that one. And then that way it stays on that record all the time. Every call goes to that one record. And
So-
if there's more than one, just pick one of those, because they haven't been merged yet.
Gotcha. Now, as a field provider, I'm responding to a 911 call.
Mm-hmm.
I encounter someone, and maybe this is somebody in my district that calls every day. So at some point, now, as a field provider, what motivates me, or what's the criteria to refer this patient to HEART? Just because I don't like them calling 911?
Well, if they're calling a lot, yeah, I would say refer. That's a reason alone. If they're calling, even if it's their true medical emergencies, somewhere that patient isn't getting the resources they need.
Gotcha.
Whether it's primary care or even other care like pulmonary specialists or cardiac specialists or diabetic clinic, whatever it might be. If they're calling 911 on a regular basis, they're not getting resources somewhere for some reason. That could be one reason they're calling 911. I always tell people that at least 90% of our people have some behavioral component into their calling 911 often.
Gotcha. So is it, does the field provider leave notes like telling you why they're referring this person?
Yes, there's a place for them to leave notes, and we encourage that because that paints a picture for us, like what they might need. We also have drop downs where it could be for fall prevention or needs social services, different things that are on that drop down. But it's kind of like a mini narrative of why you're referring them. That gives us the most information.
Gotcha.
And is most helpful.
And then what do you do with that information once you've determined, okay, this person does qualify for our services or whatever? What's your next
So the
step?
next step in my referral is, I'll read that information. I merge all the records. If it's something that, if somebody's saying this person calls a lot, then I also will look up their address in Image Trend, so that a lot of times people don't, they get patient refusals or non-patient refusals, and the name isn't they don't select the repeat patient.
Gotcha.
So it doesn't show up on the record. So I'll look at the address, I'll count all those, and if it seems like there's more, like sometimes people get the call for a public assist, so it's not going to be a medical call. So it might not be an Image Trend, so I'll look on the MDT and then compare how many calls on the MDT to that address we've gone on. And that's how I figure out how many times they've called.
Have you ever had some extreme numbers of you ever had somebody that calls 911 like a lot?
Oh, yeah. The example I always use is when we first started out, we had, and this is just one person that we looked at. We had a guy that was calling 911. He called 320 times in a calendar year.
320 times. And obviously that's not what 911 is for, right? I mean, that's not what the EMS system is built for. So the objective would be to, and I like what you said earlier, clearly he has other needs that are not being met. So your job is to, I guess, interact with this patient and then, interview them?
Well, so in that referral process, I look at what was written, what they were referred for. We also have a HIPAA consent in in ImageTrend in the reports. So if somebody's going to refer, we always ask to try to get the HIPAA consent. So that allows me to go into what we call New Mexico HIC. It's New Mexico Healthcare Exchange of information, medical information. So I'll go in there and I'll take a look and see if I have HIPAA consent, like how many times they've gone to the hospital, what they've gone for, as all the notes from the hospitals. Most hospitals are in there and notes are provided, but there's some notes don't make it on there. So, but we can at least see that they've been to the ER. After that, then I kind of go, okay, this is what this patient might need. And sometimes there'll be notes in there from a care coordinator, which means that either insurance or those healthcare providers, like say within the Presbyterian system, have assigned a care coordinator to that person, which means they're kind of assigned a social worker or caseworker.
Gotcha.
So after that, I make a phone call to the patient. If there's a phone number, try to get a hold of them. Sometimes people will leave families' numbers, which is fine because sometimes the patients aren't, they don't have a phone or they're not able to have that conversation with somebody, and just kind of touch base and find out what might be going on. And I'll always over the phone see if I can navigate them in a certain direction to help them get care before we're able to get out to see them, because we have a list of people, we have a list of repeat patients that are pending for us to get to. So if I can navigate them on the phone first, have you called your insurance for a care coordinator? Do you need, social services, whatever it might be, if I can point them in that direction, then at least they can get started on maybe fulfilling those resources.
Before you can
before somebody else can actually go visit them.
Gotcha.
Yeah.
And then when you guys go see the patient, are you doing like a full assessment? So you're looking at their physical condition, maybe the condition of the home, right? Because you mentioned falls prevention, so like trip hazards. Is that what you do? Like a full assessment?
So I think our providers are trained to see the big picture, right? Because within HEART we have other programs, right? We have fall prevention, we have a heartbeats, which is a stroke assessment. We have
falls prevention, heartbeat, yeah.
We have, of course, our repeat patient. But when they walk in, they look for things they can obviously handle, the low-hanging fruit. Is it, if this patient comes in as a kind of a repeated fall kind of situation, we'll try to fix what we can immediately. We try to just give it a once-over and make it as safe as possible and try to come up with solutions long-term. But in the short term, we certainly go in there and do what we can do.
So like if a room is packed with furniture, you move stuff out of the way, or rugs, stuff like that?
Absolutely.
Do you really?
I mean, oftentimes when, our fall prevention program kicks in for a patient, they do a home assessment. And during that home assessment, they look for obvious trip hazards. They look for what the patient is tripping. Maybe they are now using a walker because of one of their prior falls, and they can suddenly realize they can't go through a door. And so that's when we come in, do a home assessment, and determine that patient needs some home modifications, like a door widening, perhaps a ramp.
Is that where the carpenter comes in?
That's where the carpenter comes in. First, we determine what's needed, right? It could be a grab bar, it could be a floor-to-ceiling pole, it could be a toilet riser, it could be a ramp. And once we determine how many and where they need to go, then it all gets done by our carpenter.
So is your job, do you coordinate all of that? Like, once the report comes back, okay, this person needs a doorway widened, a ramp, is that a request, and then you forward that request?
Yeah, so actually it all comes in through our portals. That's why we try to remind our providers, rather than just give us a call or, go ahead and use the ImageTrend portal and put in that referral. And that referral goes to our lieutenants, and then it branches out to the different programs. And sometimes it eventually goes into our repeat patient program, which then turns into our fall prevention program. And a lot of these sometimes even stem from our stroke assessments. So we all work as one and branch off as resources are needed.
Wow. See that now I have a million questions going through my mind because there's there's a lot of things, but initially you have to figure out, like, I guess you need a baseline, right, of what's going on with this patient or why they were being referred. Because like you were saying, it could be initiated by frequent calls, but there could be so much more going on, right?
Well, that's where we get that's the baseline comes from the field, from that
Gotcha.
referral. And it comes in on that report, that 911 call that they ran on, right? That image trend report that they filled out. So when we get the referrals, I also will go look at the other image trend PCRs. So to see what is there a pattern here? Is it falls? Is it cardiac? Is it diabetic? And to see what each lieutenant has to say when they run on him or run on that patient.
Right.
Because that helps me gather information to, it seems like it's more of a fall thing. On the fall note, sometimes people will say that the patient states they just start falling frequently in the last 2 weeks. Nobody just starts falling for no reason. So that's what we got to find out next is why are they falling, And in the navigation, I always ask the patient also, have you been to your primary care lately? And if you haven't and you just started falling, it'd be a good idea to make an appointment and let them know what's going on, because maybe something cardiac is going on, something neurological, who knows what it might be. So that gets that ball rolling. And we kind of, in the Lieutenant Cert course, we also teach that, ask them last time they've been to their primary care. So, but that's how we end up figuring out what that patient might need as far as resources.
And then you can kind of call in the resource. So now, the carpenter, is a carpenter an AFR employee?
He is. It's Steve Salgado. He used to be part of CIP.
Right.
And Hart was able to bring him in and just get some wonderful work out of him. He's a true asset to Hart in general.
Well, I think it's a great resource for the city, and I don't know how many, of our citizens here, are aware that kind of service is provided. Is it so? And I'm sure that's tracked because it costs money. But how often is that happening? Like, how often are you going in and modifying someone's home?
Yeah. So on average, he does about 50 modifications per month.
Wow.
It's truly incredible the amount of work that he does. And keep in mind that some of those modifications come in the form of a ramp and several grab bars, but a ramp, it takes some time to build that out.
Yeah.
And there's certain standards that it
By
has
code,
to adhere
right?
to, yeah. And so we're just truly blessed to have Steve in our division. He does really good work.
Well, I think that's a heck of a benefit. And is there any cost to the patient?
So all of our services are free. We do work with the patient and let them know that these are the things that we can offer within reason, right? And sometimes patients are willing to buy the equipment themselves as long as we install it.
Gotcha.
So I feel like it's a good compromise.
You ever had anybody decline? I don't want that ramp. I don't want.
Yeah, and we offer the resource to them, and they're more than able to decline something. Sometimes they say, "Oh, I don't want that there," or "I'd rather not. Maybe next time." But usually, when they're calling us out, they're ready for some change. They're ready for some help.
I can imagine. And then tell me a little bit about. So we went over that heart maps. I think my notes might be wrong here. What is heart maps?
Yeah, so I have to be specific. It's modifications to age in place safely.
In place, okay.
Yeah. So it's a new thought. I mean,
To age in place.
I think I want to say early in, people wanted to be cared for by loved ones, and it seems like more and more people are being sent to facilities, right? Long-term care, senior homes, but we're trying to see there's like a new trend to have people age in their own house.
Okay.
So that requires some modifications. I think when people first build their homes, they're young and they're vibrant, and as life moves on and takes its toll, they find themselves suddenly in a wheelchair or in a walker.
Or maybe confined to a certain part of the house because of stairs or something like that.
Exactly.
Gotcha.
And so we're able to go in and just tweak their home just a little bit to make it a little bit more friendly for them to get around.
Oh, is that the official name of like what the carpenter does? Is that the name of that program?
So yeah, Heart Maps is basically the assessment, and it's all encompassed into like their home modification program, which is also part of the fall prevention. So we're all kind of one.
And then I read earlier that Senior Affairs is somehow assisting as well.
So we actually assist them. During the pandemic, they got really backed up in some of their home modifications because they weren't allowed to be in people's homes. And so at the time, it was determined that we would lend Steve to them to help them catch up. And so now he's an integral part of their day. Typically on Mondays, he goes and puts in a full day and helps them with their installs.
Interesting. Okay, that's great to know. Heartbeats.
Heartbeats. Heartbeats is our stroke follow-up program, and it stands for, so BEATS stands for Basic Education and Transition for Strokes. So we get, we've partnered with UNM and Loveless Rehab, and we get referrals from UNM Hospital for people who have had strokes. And what we do is we help them when they do get discharged home. We help them transition home by doing assessments with them, stroke assessments. We also do home assessments to see what they might need, because often people who have had strokes have, hemiparesis or issues with mobility. And we will do an initial assessment, and it's everything from the home assessment. We assess the caretaker, if somebody's there 24/7 with them that is taking care of them. Mm-hmm. There's a lot of stresses on that person. And our assessments involve everything from their medication to maybe their physical abilities to a depression scale. And we do we do that initial assessment or assessments, and then we repeat them at 30 days, 60 days, 90 days, 6 months, 9 months, and a year. So they get a total of 7 assessments.
Wow.
So we follow them throughout the year. And if anything might come up in those assessments that we might see, like a medication issue or or depression, I've had a lady that reached out to me in the assessment and really wanted some help with some of that stuff, and got her in contact with this UNM stroke support group. We try to, or what we do is try to address whatever issues might come up during that time.
So are you communicating with the physician, like when you do the 30, 60, 90 reassessments?
No, we collect data. But if there's an issue that comes up, we have a contact that we can contact at UNM Hospital that's a stroke specialist as far as an RN. And she passes that information on to try to resolve whatever that issue is that they may be having.
And is the objective to get them to, I guess, acclimate to, I don't know, their change in condition or maybe physical limitations? Like, I guess I'm trying to figure out, like, do you, like, readmits? Is part of it to prevent readmits?
That's a big part of it.
Okay.
And from what I understand, they're down substantially with the patients that we've worked with.
That's what I was going to ask.
So, yeah, the readmission and in that assessment of the home, we install grab bars or ramps or whatever they may need to keep them from falling, because falling is usually what will cause a readmission sometimes. That or medication issues, and it is to help them acclimate. I think us just showing up for some of those people, they know we're going to be there, and it's consistent. They know we're going to be there. We're going to ask the same questions, and to them, it's supportive, in a sense.
Sure. Just
having somebody there. We also make sure they're getting their therapies, their physical therapy, occupational speech. Make sure that goes through for them. But yeah, I think in the long run, some of them are really appreciative of having that continuity over that whole year, because they don't know what to expect after a stroke,
No.
And if we can help in any way with that, then it's definitely a program that has been beneficial.
So that puts 2 questions in my mind based on that. So the first question is, when you're saying it, I'm thinking, what a service, right? What kind of feedback do you get from the families? Like, you're taking care of their loved ones. Have you, like, had people pull you aside and say, hey, we really appreciate this?
In all programs, yeah, not just Heartbeats, repeat patient program. On a number of occasions, we've had that. I've had people reach out and send letters or reach out and just say thank you and for doing what we had done for their family. So, because it takes some burden off of them also, I think.
Oh.
A little, even if it's a little bit, yeah.
Well, yeah, but just to have a professional coming in, and it's one thing for me to assess my own mother or father, right? It's another thing to have a professional come in and say, I'm going to evaluate this person based on my clinical expertise.
Right, and you know what to ask because you're a paramedic.
Right.
Many families don't know what questions to ask or what even to expect. So it's, I think in all the programs that's helpful, and it's been beneficial for the families too.
Yeah, I think that's, and then the next question on that is, so when you were mentioning that there's a reduction of readmits, that's tracked, like you have that data?
We have that data. So if I'm not mistaken, the number is like a 50% reduction in readmission rates. That's humongous.
Yeah.
And so we're doing a lot of good for a lot of people every single day through all of our programs, but it's definitely huge.
So then what do you do when, let's say, like, you have a lot of elderly patients? What if transportation is an issue for them? Like, they can't get to their appointments.
So transportation is also another big challenge that many of our clients and many of our patients deal with. Mm-hmm. Both in heart and also just in the community in general. But we have a Uber Health program where we can offer rides to our patients to get to the pharmacy, to get to their doctor's appointments, anything to do with their health and well-being. We can provide transportation to and from.
And that's like non-emergency medical transportation?
Exactly.
And Uber has that business now? I didn't even know
So they have an Uber Health program, and they've been very helpful. It's been.
But it's just rides.
It's just rides.
Okay.
As long as the patient can ambulate into the Uber vehicle, they qualify.
Okay.
I will say that AFR tried to launch a pilot program where we can utilize that Uber Health ride within the 911 system, and so we've been getting some usage. There are some field providers who have been calling that number, which calls us, and we schedule the ride. And the only thing we ask.
Oh, I see what you're saying. I respond to a call. It's not emergent. All they need is a ride, so I'm going to call Uber Health as opposed to transporting them in an ambulance.
Exactly. Although when you call the number,
I'm calling.
It's really calling our heart providers, and then we get it scheduled. But it's very helpful. The only thing that I would like to say is that there are some parameters that we try to adhere to. Hopefully the patient's 50 years and older, although every now and then we're okay with outside that range. And it has to be to some sort of health-related ride, right?
That makes
Pharmacy,
sense.
the grocery store to pick up meds or medicine, a doctor's appointment, PT, OT, Alcoholics Anonymous, anything along those lines. And the field provider would, ask the patient, can we offer this for you? If they accept, you take a non-patient refusal and go ahead and clear the call. And we'll take over from there and make sure that patient gets to their appointment as well as get back to their home.
Is there a limit to how many rides a person can have a month?
No, it's a service we provide, and the more we can help, the more we're willing to help.
It's free.
It's free, absolutely free.
I didn't know that either. I thought like this is like an occasional kind of thing. I didn't know that it was something that reliable transportation.
Yeah, and the people that use it actually use it pretty frequently, and once they realize the benefit from it, it completely improves their well-being.
Yeah, man, because if people can't get their meds, they're not going to be compliant. I mean,
Exactly.
That's pretty impressive. So you have a K9, right? Mm-hmm. I've met her. What's her name again?
Wrigley.
Wrigley. I always get Wheezy and Wrigley mixed up for whatever.
Two
They're both
W's.
very cute.
Wrigley's the Cubs field, so just remember
Okay.
Wrigley
Okay.
Field.
All right.
She was her litter actually was named after all ball fields. So
Really?
yeah,
Okay. So she has a dedicated handler?
Yeah, Captain Jake Gray is her primary handler, and I'm her secondary handler, and Athena is her third handler.
And specifically, what does she do?
So she will go out with us to patient visits. There's been times where, sometimes especially with repeat patients, sometimes they don't want to talk to us. And you have a cute dog with you, everybody's a sucker for a dog. Most people are. And so sometimes she gets us in the door. If we can't get us in the door, then she can sometimes get us in the door and kind of change the level of whatever that interaction will be with that patient, make it just smoother and easier conversation with somebody.
That's it. Wow. Her job is to make people feel more comfortable, and
yeah,
she's a love dog.
Yeah.
I mean, that's what she, right?
Yeah. She's inviting. When you see her, she's happy-go-lucky and happy to see everybody, just like most dogs. So she breaks the ice for us a lot of times.
I love dogs. Did you have to get a special training? For that?
Yeah, there was. We started it before COVID. Unfortunately, that kind of set things back because a lot of this training was in a group setting. Mm-hmm. But yeah, there was 2 weeks of classroom training, if I remember correctly, and then there was training out in the community. So there was pretty extensive training, and it wasn't just teaching us how to be with her. It went in pretty far in depth of how dogs react to different things, how they can be affected, how they can affect other people, and how to get her best work out of her. So
interesting. Yeah, I knew it was pretty detailed. And then as we start to try to bring this to a close, I want to ask, how does your work affect you personally?
I'm sorry.
Why, we're going to go there?
No, that's fine. In the very beginning, when we first started this program, in the first 3-6 months, whatever, people would ask, so how's the heart program? And I had to tell them this was the hardest job I've ever had. It is legitimately the hardest job I've ever had.
That's why I ask.
And granted, I have to preface that with, in the beginning, we didn't know what we were doing. We didn't know, we were trying to get in and jump in and fix everything and, keep all these people from calling 911, and jumped in feet first and learned very quickly. There was a very sharp learning curve that we couldn't do that with everybody. And in addition to learning, the navigation, how we had to navigate. So it has been the hardest job I've ever had, but it's also been very rewarding.
I was going to ask about that.
Because when you do see somebody you've been trying to help and they in turn follow through and help themselves, that's what we want to see. I always tell people I don't want to enable somebody, I want to empower them.
Right.
I want to give them the resources and teach them how to use them, and then watch them run with it and see what they can do with it. And we're always going to fall down, but and that's why we stay with the patient. You have a problem, we can help you get back up and get back on track. So it has been very rewarding also. So
there's stress involved, a stress level involved with it?
A much higher stress level. I think in the field it's a different level of stress than in the field.
Sure.
You run on that person over and over and over again. You're like, that's the chronic stress of seeing that person over and over again. Well, we go and sit with that person for 2 hours at a time, sometimes in the beginning, to try to figure out what it is that they need. So that level of stress is higher. And, you can put them in a 5-5 unit and send them on their way when you're out in the field, but that doesn't happen with us.
Because you are.
The phone calls come from them or whatever it might be, providers calling for them.
Have you had patients that somehow you become attached to each other and then they're calling you directly?
Yeah, well, and we do give, for some of those people, I will give them my work cell phone. And so, but I also let them know that I work from Monday through Thursday from 7 to 5:30.
Are you able to turn it off like that?
Well, you have to.
No, I mean personally, like, can you, like, because there's got to be times where people just, I know it's Saturday, but I needed to talk to you.
I turn the phone off.
Do you really?
But I do. There, you know, even though it's Saturday, I'll be like, I wonder if so and so got out of rehab, or you know, I wonder if, you know, they made their Uber ride that was scheduled on a Saturday that we don't answer the phone for anymore. You know, we schedule it and hope for the best. You know, so you can't completely turn it off. No,
Right.
I may turn the phone off, but we still think about hoping that, and I will sometimes still get on Image Trend and go, okay, yeah, they didn't call. All right, we're good. You know, or on the MDT.
That's kind of what I was wondering. Like, you can't completely separate yourself from it because you're in it, right?
You do get attached to them. You know, you work with them for a while, and you know, we try to set limits on the time frame that we work with them. But like I said in the beginning, we didn't have as many limits. We didn't have as many boundaries, I guess. And now we've learned that we had to create those in order to maintain ourselves.
100%. What about you? So, because everything I'm hearing and just a little bit I knew about it, to me, I always think about it from kind of the macro level, like on the city. You know, I'm really proud of our city and our department to be able to do this. Like, these are tremendous services that many people need, but I don't know if it's in the forefront of people's minds. Like, not something people think about.
Right.
So has this been rewarding for you as well?
I have to say, I feel like the luckiest man in Albuquerque Fire Rescue. I stepped in this role about a year ago, and since it's been a whirlwind of learning new concepts, learning new terms, learning to not say no. You know, I got an outstanding team who are like-minded, who are all about the patient care, and I've learned that you can't say no. I learned that you have to find reasons how we can help this patient, no matter what their challenge is.
How can we find a yes?
Yeah, no matter what their challenge is, Heart has always tried to fix it, and more often than not have fixed it. And
is that a skill, or is that something that has to be in you? Like that level of, and that's kind of what maybe I was getting at before about like, I don't like the term, and I know like compassion fatigue people talk about, like you're just inundated with all this stuff, but you have this, I guess, the stamina or the makeup to, you don't want to say no. You don't get tired.
Well, I guess I have to say that I love the fact that my providers have found their boundaries, usually, and they know what they can help with, and they know what they can't. And if they can't, they find resources to fix those issues. And I love the fact that they're willing to spend 2 hours in a home and just figure it out.
So they get creative.
They get super creative, and that's why I say I've learned to not say no to something, because they fix stuff. And you know, the joke of like, I joined the fire department to help people, right? We've heard that joke.
Oh yeah.
We're truly doing that in Heart.
Right.
Truly. And our field personnel have really appreciated some of the accomplishments that we've done. We've eased their burden quite a bit with some of these patients. And quite honestly, the patients deserve this kind of service. But you can't fix a lot of their ailments within the 911 system. They're better served outside of that. And so
sometimes people could get, like, there's a misconception that we want to reduce call volume because we don't want to work.
Yeah, absolutely.
But that's really not about that.
I don't think that's the case. Honestly, I've learned that our providers truly care about their patients.
Right.
And they want a continuum of care outside 911, and that's where we step in. And not to say we don't have a magic wand that we fix it every single time. Heart and participating within Heart is truly voluntary. We can't force people to let us help them.
Sure.
Although we're pretty persistent. We have our ways to get in. Wrigley certainly greases the skids a little bit. Sometimes a food box gets us in the door, start that dialogue, and before I know it, patients trust us. They trust that we're going to help them, and our providers in Heart work to earning that trust, and ultimately work towards a solution so that they don't have to call 911.
That's excellent. How important is it, like your clinical knowledge? Because I know all the members of Heart are all paramedics, right?
We are all paramedics. So our providers have to show up. So let's just say, for example, someone has fallen down. It may not be mechanical. It may be medical. And so we got to go in there and look at their medicines, look at what kind of health struggles that they're suffering from, and try to put it together, try to figure out what is truly causing them to be dizzy.
Right.
It may be medicines. It may be nutrition. It may be social boundaries that they're trying to deal with. Mm-hmm. So it's important to come with an open mind, have that clinical knowledge to look at their medicines and determine, like, is this causing their falls? Sometimes it works and sometimes it doesn't, but we're always working towards our higher training to figure out the problem.
So you think it is important for the providers to be paramedics and have that?
Absolutely. I think especially in those first initial appointments, you got to really get down and try to find out what's causing the problem and how to fix it.
Gotcha. That's a great point. So both of you, I want to tell you, I appreciate what you do. I appreciate you guys being here and kind of educating us. For the most part, this podcast will go out to the field first because this is kind of the point of it all. Fire Chief Jaramillo wanted us to sit down with each division and kind of get an understanding of what the division does and why, and kind of how it fits into the whole family of AFR. So really appreciate it. For those of you that are viewing this, we appreciate you watching the videos. Comments are helpful for us. It helps us to improve the product. We're always improving. You guys can give me healthy advice about growing my hair out or whatever, some of the other colorful suggestions I've been receiving. I said it before, but I always end with please subscribe, hit the like button, hit that notification bell, and leave a constructive comment. We'll see you on the next one. Thank you.